Hello and welcome to Keep Talking, a community dialogue about mental health. It is brought to you by both the Brattleboro Retreat and Brattleboro Community Television. We have today a discussion about celebrating 20 years of Starting Now. Starting Now is an intensive outpatient and outpatient addiction treatment service that the Brattleboro Retreat has offered now for 20 years. And it provides help with addiction recovery over the long haul for people who have been affected by the great suffering of addiction, both the addict and family members, and help from people who really understand that addiction causes great suffering. Today I have with me Kurt White, who is our clinical manager of Starting Now and the Birches. And he is a social worker and drug and alcohol counselor at the retreat. He started at the retreat in 2005 in the co-occurring disorders unit. And also with me today is Dr. Jeffrey Kane, who is the Chief of Addiction Services at the Brattleboro Retreat. He has been the Chief of Addiction Services since 2003. He's been in the addiction field since 1974. He also has a Master's of Public Health. And he's the author of a column called Addiction Medicine Updates for the National Council of Addiction and Drug Dependence. So, Starting Now, 20 years. There were some things we wanted to cover today to just get a sense of what you have experienced in the addiction field. You have both not been at Starting Now for 20 years, but you certainly have been around addiction treatment for that amount of time. And one of the things that we really wanted to cover today had to do with treatment, medication, levels of care, and style of care. And I just want to start off with you telling us a little bit about your own personal experience with treatment and what you've seen, how you've seen treatments change in the last 20 years. And we'll start with you, Dr. Kane.
As you said, Gay, I've been around the addiction treatment field for a long time, and there are some very dramatic changes in the last 20 years. Though turning back to the late 1900s, that was a time when what people have come to call the Minnesota model was kind of gaining sway in treatment circles. And back in the mid-20th century in Minnesota, a number of sort of factors came together in treatment programs, Pioneer House, Hazelden, Wilmar State Hospital, where people brought together the latest science with personal experience, sort of medicine meets AA. And it became the dominant approach to treatment to the end of the 20th century. And more science has come in, more techniques have come in, but when Starting Now began 20 years ago, it was a continuation of that approach to treatment with a blending of sort of medicine and science about addiction and recovery, and also drawing on the wealth of practical wisdom and personal experience that had been growing since the 1930s.
And what do you see in retrospect in your time? What have you seen, and how have you seen treatment change since beginning your practice? Yeah,
well, I've been in practice a bit less long than Dr. Kane has, but at the retreat for a similar amount of time. Even in that period of time, one of the most noticeable changes in the addiction treatment world is a greater prevalence of medications to treat addictive illness, greater use of existing medications, new uses for some medicines that were on the market but weren't being used for some things, and new formulations of them, and actually new medicines that have been developed and released onto the market in that period of time.
For treating addiction, also for treating psychiatric illness. Yeah. I mean, 20 years ago, we didn't have the antidepressant medications and the antipsychotic medications that are sometimes used for sleep and anxiety and other things. So there's been a remarkable development of medication, psychopharmacology, but also brain research. And we know a lot more now about what's going on in the brains of people with addictive illness than we did 20 years ago.
So 20 years ago, someone would show up for treatment, and what would be the protocol at that time? What were the steps that someone would take at that point that are different from what would happen today?
We might put the Starting Now program in perspective. It's an intensive outpatient program where the treatment personnel are predominantly counselors, and it's largely group-based, so there's group counseling and individual counseling. And it goes on for several weeks, 10 weeks or so. And the people that come in tend to come from two sources. One would be the hospital, people who have had physiologic dependence on an addictive substance, alcohol or opioids, and they needed a medically managed detox. So they would step down from the hospital into the intensive outpatient program. The other source of patients, though, is the community, people who would learn that or recognize that they've got a problem, or perhaps be levered into treatment by family or an employer or the legal system, and they'd come into treatment but without a serious enough level of physical dependence so they didn't need a detox, but they would come into this structured setting and move on there. And this would, especially with the duration of treatment, give people a chance to learn to cope with their illness, learn what they need to do and not do to remain sober, and get networked into other community resources that would sustain them after the end of the program.
Mm-hmm. I see. And what I've learned as I've worked at the retreat, and I've only been there for about 4 years myself, is that there was really a change in how addiction has been looked at. It was looked at more as and maybe you can speak to this, Kurt, at some point it was sort of looked at as a moral weakness, psychological disorder, and over time we've learned a lot about it and framed it in the frame of chronic illness, much like one would frame diabetes. And could you speak to that a little bit?
Diabetes, hypertension, asthma. Sure. But actually, the idea of addiction as a disease goes back a long way, longer than many people understand. And it was, in fact, the dominant way of thinking about addiction in the 19th century, and it actually kind of fell out of fashion in the early 20th century, late 19th, early 20th century, when more of those sort of moralistic views that the problem is not a disease but is a moral failing of the person that came back into to hold some sway, and also the idea that the problem wasn't the disease of the person but was the substance itself. And you see that most notably in the prohibition movement in the early part of the century, and then the successful prohibition efforts, not just on the federal level but in many states and local governments across the country also. And then the disease idea had to be sort of almost rediscovered in the 20th century. Some people associate this most with Alcoholics Anonymous, and that group does definitely have a part in it, but there's been a great deal of more sort of nuanced description of what we mean by disease. When we say addiction is a disease, what kind of a disease is it? And what does that mean? And why is that important? And what is it? And why do we talk about that and teach that to patients and patients' family members?
Why do you teach it to patients?
Because it gives some major clues into the way that you handle that to have the best possible success in treating this disease, which, if left untreated, can be progressive and life-threatening. That it gives us the best chance of being able to provide the most effective kinds of treatments, both in the immediate time when people need the most intensive treatments, and also over the longer course of sort of health maintenance and disease management. Right? There's a 1990 paper by Thomas McClellan and others who was at the Centers for, no, he was at the a government agency, and who was talking. There was a paper by Tom McClellan and others in the year 2000, I think, by talking about drug addiction as a chronic illness, where it compared it to diabetes, hypertension, and asthma in terms of the causes and in terms of the ways that that there is a genetic linkage, the physiologic impacts on the body, and then how we ought to think differently about treatment as a result of it. Mm-hmm. Now, those diseases are different than diseases like influenza, which hopefully you get and then you get treated and then you hopefully have cure. No more influenza. Mm-hmm. The idea there is that you get treatment for it, but there is perhaps a remission of the disease state or something like that, or something sort of new and better that we talk about in the addiction world of recovery, that we can pursue and help people cultivate over the longer course of their lives to maintain the kind of health that they want to have. It becomes more of a long-term process than a short-term process. It's not come into treatment and have treatment, and at the end of it you're done. It's come into treatment, and then you learn about what it is this illness, this disease means. What does it mean that you have it, and how can we work with that in order to help that person have the life that they want to have.
And oftentimes the addiction goes hand in hand with what we call, and this is where I can ask you, Dr. Kane, more about the concept of co-occurring disorder. When did we start using that term, and what does that mean exactly when you hear that? And for instance, when a family member hears that, what does co-occurring disorder mean? I'd
like to answer that, but I'm still with Kurt and history a little bit.
Okay.
Here. If there are viewers who would like to who don't have access to Kurt every day and would like to get more of a view of the history, the book by William White, Slaying the Dragon, A History of Addiction Treatment and Recovery in America, is exhaustive and with a certain amount of color and detail. Rehearses that whole progression, and it's widely accessible. As far as the think about addiction as a disease is concerned, diseases are kind of categories that we use in medicine to classify people who have enough problems in common that they respond to similar treatments. So they're convenient and they fit with technology. And with the brain science that I mentioned before, with the medications that Kurt mentioned, it's very convenient to think of addictions as diseases, and it's very helpful to patients affected by them because it gives them a way of understanding this process that's been taking over their lives and provides them with tools for coping, including just simple acceptance and naming it. So it demystifies it and gives them a handle on it. Co-occurring disorders is a term that we use to refer to people who have one or another forms of mental illness in association with addiction. And back 20 more years ago, the approach was clumsy at best. People thought, well, we'll take care of the addiction and then we'll get around to taking care of the mental illness. So we'll take care of the mental illness and then we'll get around to taking care of the addiction. But when people tried to approach it sequentially, the problem that wasn't being addressed was messing up everything that was being done for the problem they were trying to address. And people talked about using terms primary, secondary. Well, this is what's causing the other, and that didn't work very well. And then primary, secondary. Well, this came first, and the other came second, and that didn't work very well. So finally, as sort of a truce among professionals, people started to talk about co-occurring disorders. They're happening at the same time. We know we need to treat them both. And what the research showed is, yes, that's the way to think about it. And when they're treated together at the same time with the same treatment staff, that's the most effective form of treatment, which goes back to what you mentioned before about a reference to Tyler 1 in the retreat, where Kurt has worked, where I worked with
That's
Kurt.
That's a floor. Tyler 1 refers to a floor at the retreat.
Yes, an inpatient treatment unit. We call it the co-occurring disorders unit.
Yes.
And most people there have addiction, most people there have a mental illness, and it's sort of a full-service psychiatric unit and a full-service addiction treatment unit, with a lot of people being detoxed. And the treatment staff are savvy about both areas. When I worked at a hospital in New Hampshire, probably 20 or a little bit more years ago, I was on a committee where we were supposed to develop a dual diagnosis program, which is the older term for co-occurring disorders. And we met and we talked and we met and we talked and we never got anywhere. So after a while I said, well, at this hospital we have 2 dual diagnosis units. We call them adult psychiatry and adult chemical dependency. There's so much overlap in both places, it didn't seem, if we opened a 3rd unit, we would have emptied the other 2.
I remember one of the counselors who works in Starting Now was telling a story about one of the first jobs that he had, where he was the first substance abuse clinician hired into an agency that did mental health counseling and didn't pay very much attention to substance abuse at all. But some of them began to suspect that maybe some of their clients, maybe some of them had substance use problems that might be making their mental health problems worse. I think that was how it was conceptualized at the time. And so they hired him on, I think, at 20 hours a week in a facility that had, 20 or more other clinicians. And he said it took a little while, but people would sort of come and eventually start knocking on his door. And then it was sort of like they couldn't get enough of it. They couldn't get enough of his time. The more that people would talk with him, the more people were aware that if you people who were conceptualizing treatment through the mental health lens only were sometimes missing a substance use piece that was impacting those disorders, or was even driving the mental health symptoms and disorders to some greater or lesser extent. And so now we really try to be, no matter what door someone first comes into, we try to assess comprehensively substance use and mental health problems as much as we can.
Can you give me a chance, because I want to touch on this a little bit, because I think this is important in terms of the layperson understanding this a little bit more too, is what has changed in terms of medication. We spoke about this the other day when we were prepping for this. A lot has changed in the last 20 years. And obviously, if people are looking at mental health issues with addiction issues, then there must be a lot of thought put into whether people need to be on medications when they have an addiction problem. What does that mean? Let's
set aside the whole issue of psychiatric medication, which some of these people need, and talk about medications for addiction. First, alcohol dependence or alcoholism, and then opioid dependence. 20 years ago, what we had as medicine for alcohol dependence was disulfiram, Antabuse. Years ago, rubber workers started to get sick and throw up on weekends, and researchers eventually figured out that a chemical used in the processing of rubber, disulfiram, was getting absorbed by them, and it turns out that this chemical blocks the breakdown of alcohol in the liver. So if they then drank, they would all of a sudden get a lot of acetaldehyde, which normally there isn't much of. The enzyme that gets rid of it is blocked by disulfiram. So that led to this medication, better known as Antabuse, and people who are alcoholic and they definitely don't want to drink take this every day, knowing that if they were to, in a moment of inattention or whatever, take a drink, it would make them seriously ill. And that's been around for decades. In 1994, Naltrexone, and I'll mention this again with opioid dependence, but Naltrexone, which had been around for a while for the treatment of opioid dependence, was approved by the FDA for treatment of alcohol dependence. It blocks the endorphin receptors, the opioid receptors in the brain where morphine would go, heroin would go. It doesn't have any action there, but it affects the reward pathway in the brain. And people on it seem to, if they're alcoholic, they seem to crave alcohol less. And if they do, so it helps before the fact of picking up a drink. But after the fact, it helps by removing some of the pleasure or reward of the alcohol so they don't get as high, so they tend to drink less. A third medicine, a camprosate, also known as Camprol, has been approved in the United States, I'm going to guess 6 years. It's been used in Europe a lot longer than that. And we think it works on the glutamate receptor in the brain, and seems to make people less likely to just pick up a drink on automatic pilot, and the testimonials from patients support that it's pretty effective. The latest research shows that it's not as effective as naltrexone. Mm-hmm. As far as opioid dependence is concerned, 20 or more years ago, we did have methadone as a groundbreaking drug for stabilizing people with, especially heroin addiction in inner cities, mm-hmm. and it would stabilize the brain, keep them out of withdrawal, relieve craving, and the statistics were great in terms of reduced crime, increased employment, better, more stable families, less infectious disease. And then the HIV epidemic came along, and it seems to reduce new HIV infection as well, mm-hmm. And is often a lifelong treatment. Relapse rates when people go off methadone maintenance are pretty high. Some people come off for good reasons, some people come off for bad reasons, but still relapse rates are pretty high, like 20%. Mm-hmm. 20% success, I should say, 80% relapse rates. And in 2003, buprenorphine in the form of Suboxone, a sublingual preparation that is also an opioid, also goes into the endorphin receptors, was approved for treatment of opioid dependence. Or it might have been approved in 2002, but wasn't available till 2003. And that's available by prescription. Doctors in their offices can prescribe it. Kurt and I are both involved with a large program at the Treat with some 130, 150 patients who come on a regular basis for prescriptions. And it also provides some of the benefits of methadone for stabilization, and it's more convenient for the patient. They don't have to go to the clinic every day.
So this must represent a remarkable change in what you're seeing in terms of outcomes and how people can live their lives.
It does. It provides a sort of a physiologic platform for people to stand on to pursue recovery. Mm-hmm. One of the downsides is we have trouble convincing people that that's not enough. It provides a platform, but it doesn't build the shelter, which people do in interpersonal relationships, in therapy, in mutual help programs like AA. And we try to ensure that people get that message and do that also.
So, Kurt, if we were to talk about that in terms of levels of care, and because I wanted to touch on the levels of care, I wanted to touch on the style of care, the changes that you've seen, but also I want to also fit in some questions that family members may ask when they have a loved one end up in addiction treatment. Could you speak about how the retreat, for instance, somebody comes into detox, they go to Tyler 1, for instance, which is the co-occurring disorders floor. They're in there, they get detoxed. Is the next step that they go to starting now? Is the next step that they go, for instance, to the Birches program, which you're also the clinical manager of? What are the steps?
Well, it would depend a bit on a number of factors. The American Society for Addiction Medicine, or ASAM, has a document, the ASAM Patient Placement Criteria, second edition revised, that sort of goes through and sort of helps providers who are working with clients to try to match people to the kind of treatment, the intensity of treatment that would best help them for where they are. That is actually one of the shifts over the last couple of decades, I think, is that the approach to where you put people in treatment, at what level of intensity, be it residential rehab, like a 2 to 4 week residential rehab, or longer residential treatment. There are some longer programs that are still out there and exist, or something like an intensive all-day program like partial hospitalization, or something like it's starting now, intensive outpatient, which is sort of less than partial hospitalization, but still quite intensive, that you'll come in several times a week for several hours a day.
Yeah, and there's both an evening and a
day program to accommodate people's different schedules and work lives. And some people are able able to just come into treatment, perhaps not so much through detox, but to come into treatment and just need treatment at the outpatient individual level of care. And there are different factors in terms of how much support does the person have in their outside life, and what other sorts of treatments have been tried successfully or unsuccessfully in the past. What's the what's a bunch of different factors all go into that determination. Whereas I think it would have been more likely 20 years ago for people to sort of start out in something like a 28-day program without a lot of distinction being made about who needs that or more than that and who needs that or less than that.
Yeah, at the beginning I mentioned the Minnesota model as where science and experience came together. The experience dimension also includes positive spirituality. But another association with the Minnesota model has been one-size-fits-all treatments. And during the years that I've been in the field, there was the rise and decline of 28-day or 30-day programs. 25 years ago, if someone came into a hospital for addiction treatment, they would probably be there for 4 weeks whether they needed it or not. Now with the crisis in healthcare costs and responses to that like managed care and the development of more scientific approaches like the ACM criteria that Kurt mentioned, it's more individually tailored. We hope people, if they touch the treatments system, like Kurt said before, there's no wrong door. The professionals will kind of organize it and help them get what they need and proceed along a path that's tailored for them.
And the good news, the really good news is that people, that in Vermont we have many of the different ASAM dimensions, many of the different levels of care, from residential, intensive outpatient, and even some longer-term residential treatment that's available, paid for through the State Department of Health, ADAP, the Substance Abuse Services branch of the Department of Health, and that we can, and that many people can get better with less treatment than they used to get necessarily, or less level of intensity, and so it's less interrupting of people's lives. But if more treatment is needed, then it is available, and we can often help move people in that direction.
And back to the sort of disease concept and the chronic disease concept. Ideally, people do lots of self-care and self-management. If I have high blood pressure, I may take a medicine, but I also need to be careful about diet and exercise and weight and things like that. And a lot of that would be on me as an individual person or patient. And what we try to do in the progression through treatment is help people to get better at addressing their own needs and taking care of themselves, learning what they're up against. It's the nature of addiction that they can't trust themselves, they have to keep their distance and not think that they can take just one. And they also need to grow as individuals, grow in resilience, so they'd be less likely to care about escaping reality. They'll enjoy reality too much. And that's where the interpersonal forms of treatment come in, group, individual therapy, and
sustain relationships with a program.
And recovery supports in the community.
Yeah, it tends to shift from program to the community. And the main paradigm would be Alcoholics Anonymous, also Narcotics Anonymous, mutual help or self-help programs in the community where people often get very involved and stay involved. So it's like, I don't know, I don't need to see my blood pressure treater very often because I'm in a health club, and maybe I show up every once in a while. Now, we think it is advisable for people to be accountable to someone for recovery. So some people complete starting now, and they come back to the same, one of the same staff members for a relapse prevention group. And then after a month or 3 of that, they may still see that counselor a few times a year for encouragement and also accountability. And in 12-step recovery, sponsors can provide that form of accountability. When someone's on a medication, be it Naltrexone or Suboxone, there's some built-in accountability because they have to show up to the prescriber and say what's going on.
Do I get a sense when I talk or ask these questions of you, do you feel optimistic about the changes and the direction that drug addiction treatment or addiction treatment is going at this point?
Oh, absolutely. Yeah, absolutely. I think the more good science we have behind it, the more we'll be able to do, both with talking therapies and interpersonal treatments, and also medication treatments and the like on the medical end.
Mm-hmm.
And science is guiding the interpersonal aspects of treatment.
Absolutely.
20 years ago, it was fairly common for counselors to argue with patients, and in group maybe put them in the hot seat and remind them of their mistakes, and that proved to make it more likely they'd leave treatment and go back to alcohol or whatever the drug was. So it was toxic to them personally and to their recovery. Now there's more empathy and understanding, still a reality-based, holding people accountable for what they've done and not done, and reminding them of where those behaviors will lead them back if they persist. But also it's more empathic, more understanding, and there's more communication of hope rather than reminders of pain.
Yeah. Let me ask you just a few questions related to perhaps the family members, friends who are watching this program today. Suddenly they have a loved one who enters addiction treatment. For alcohol, it could be cocaine, it could be crystal meth. What should they be expected to understand? What can they hope to understand? And how would you help to guide them with first the initial period of time and then also that long haul?
Well, I wouldn't necessarily expect family members to initially to understand anything at all about addiction or what treatment is going to involve. And so there's a lot that we have to do as providers to educate and help people understand what that's about. What is the person in treatment doing in treatment? What were they, and to speak with them about what was going on at home for them, and also for the person seeking treatment and also for the loved one. And I would want to encourage people, family members, to also remember that you need care also. That addiction is an illness that affects the entire family, and that it's very important for everybody involved to get a significant amount of support as a result of that. There are organizations like AA and NA for the addicted person, and then for the family member support of others, there are Al-Anon and Nar-Anon for the family members working with the person with family members of a person with an addictive illness. And so I would want to introduce them to what the treatment process is going to be like for the person, introduce them to addiction and what it is, including the idea of it being an illness, a disease, and a chronic disease that needs both acute and longer-term attention, and to ways that both the loved one and the family will likely need support in the immediate sense and also over the long term.
And Dr. King, I wonder what you would say to a family member, for instance, about measuring success. How does a family member kind of have a sense that things are going well or not going well, or that's a pretty hard thing to measure. Maybe they shouldn't even be thinking about that. They should be thinking about themselves.
If it's addiction, is there drug use or not? Is the drinking continuing or the drug use continuing, and the behaviors that go along with that? I think it becomes difficult for family members when a family member has established recovery and then gone back. Mm-hmm. And I sat with a spouse once who was deciding to end the marriage after so many relapses because the spouse just wasn't prepared to watch the progression. The love was there, but it was too hard to watch and be close to. And people and families have to decide what their sort of tolerance might be. I've had many conversations with parents saying, you're in a tough spot, I don't have the crystal ball or the wisdom to know what to do, but acknowledging that on the one hand, if they're too harsh, if they're too tough with tough love and say, okay, you're out of here, I mean, that could possibly lead to the death of their child due to addiction. On the other hand, if they're too forgiving and don't hold them accountable to their behavior and what they're doing and not doing, then they make it too easy to stay addicted, and that could cost them their child as well. And the middle ground is setting some limits and holding the person accountable to meeting them, and then following through with whatever the stated or agreed upon consequences would be. You mentioned the Addiction Medicine Update column, and at www.ncadd.org there's about 10 of these columns now, and one in the spring was on intervening on alcohol style matters. And the style that's effective is firm and also loving. And a woman modeled that for one of our treatment teams, and for myself. Her husband was alcoholic, professional guy, but stayed drinking, and she said, I love you, I admire you, I admire your work, and this drinking is messing up my life so much that I will not stay in this marriage. I want you back, but there's no room for alcohol. And she put conditions on his completing treatment with us. He thought he was ready to go, and also put a condition on that he go away to a 3-month program geared toward helping professionals get a better handle on things.
Speaking of your column, you just wrote a column about the holidays, and the holidays are a really tough time for families, whether the addict or alcoholic is drinking or not. It can be a tough time. Do you have any sage advice, both of you, sage advice for people who are, Thanksgiving's a couple weeks away. There's a lot of drinking, and there's a lot of imbibing in various, even food can be can be an issue. But what would you tell people about thinking or planning for the holidays?
I would tell them, be careful. Right. I mean, that's the sort of central message. It's a time, among other things, of a lot of social and cultural permission giving around drinking alcohol. A disproportionate amount of all of the alcohol that's consumed the entire year is consumed in the 40 or so days between Thanksgiving and New Year's. And so this is a time when people are likely to feel an external as well as an internal pressure to use, and for those that have an addictive illness, that's going to be all the more greater, exponentially greater, especially if that person is in an earlier sort of recovery. And so to be careful and to take precautions about it, knowing that that's probably going to be a difficult period. And you might say more about that, since
echoing be careful. Precautions. Going to a social gathering.
Yep.
Well, stay away from social gatherings where maybe getting intoxicated or high is expected behavior. There are social gatherings over the holidays that are substance-free. Alcothons, for example, that exist in this community at holiday time. Going to a social gathering, bring your own beverage. that might be non-alcoholic. If you're hosting a party, make sure there are plenty of non-alcoholic selections, juices, seltzer, fruit, lemons, limes. And if somebody puts out punch or eggnog, make sure it's labeled with very sturdy labels that it's alcohol-free or contains alcohol.
And maybe it's even okay to have parties where there's no alcohol.
Yes.
Yeah.
Yeah, especially if you're underage.
It's true. It's true.
Many people don't miss it at all, and it's sometimes if a person has been particularly used to holidays that have involved a lot of substance use, it can be hard to imagine that that's true. But it really is true that despite the increase in consumption at this time of year, there are still a lot of people who don't use at all, or who use very little and attend quite a lot of substance-free gatherings. And so to seek those out and develop them yourselves if you aren't able to seek them out. I should put in a little plug for the also Vermont has a pretty groundbreaking network of recovery centers. In Brattleboro, there's a Turning Point of Windham County. They have quite a number of free, open to the public events that are alcohol and drug free. They have times when the center is just simply open and people can come in, play pool, have a good sober time with others. If people are looking for a place to do that, Turning Point of Windham County, you can find information about them on the internet and around.
Well, I want to thank you so much, both of you. Kurt White, who's the clinical manager of Starting Now in the Burgess program, and Dr. Jeffrey Kane, who's the chief of addictions not the chief of addictions, but a chief of
Addiction services.
Addiction services, that's right. And I want to thank you so much for taking the time to do this. I know that both of you are very busy, and it's a wonder that your beepers haven't gone off as we've been talking, except I made you turn them off. And also, congratulations on Starting Now. 20 years is an amazing record, and you all should be really proud of all the good you're doing out in the community. And thank you for joining us, and we look forward to coming back, the Brattleboro Retreat, and having more discussions like this on Keep Talking, a dialogue about mental health. Thanks.